Hello friends, today we are going to discuss this question which was asked in the DRMB critical care exam in June 2022 regarding albumin, and the question was function of the albumin and the evidences of the albumin. So albumin is the natural protein that is produced exclusively in the liver in amount as high as 9 to 14 gram per day. The median half-life is 18 to 90 days. So albumin is responsible for maintaining the fluid between the intra and extracellular space. Albumin is responsible for 90% of the colloidal osmotic pressure. In critically ill patients, the interaction between the colloidal osmotic pressure and the albumin is complex and is significantly affected by increased capillary permeability and precapillary escape. So not only this, the albumin also has the immunological effect. So the role of PGE2, it is acting as the immunosuppressant agent in patient with the liver cirrhosis. If you infuse albumin, then it decreases the level of PGE2, which will reduce the risk of infection in cirrhotic patient. So this is the diagrammatic representation which showed the interaction between glycocalyx, albumin, and the interstitial space. So the current understanding of the vascular barrier function in high pressure segment of the vascular system include glycocalyx. The intact glycocalyx barrier competence is preserved even at the albumin concentration at less than 10 gram per liter. The green arrow showed the colloidal osmotic pressure, keeping the fluid in the vascular lumen, while the blue arrow demonstrates the driving pressure out of the vessel. And the purple arrow shows transcapillary fluid flow, which results from the complex interaction of endothelial cell, glycocalyx, and albumin. So these are the studies which was published in the context of albumin. So first study was SAFE study, which was published in 2004, which compared 4% albumin and 0.9% saline, and it showed the similar outcome in terms of mortality, organ failure, and ICU length of stay. Uh, and it showed the uh, reduced 28-day mortality and reduced vasopressor use in septic patients. So according to the SAFE study, the albumin was useful in patients of sepsis, but not in patients of the trauma. Then EAR study was published in 2011, which again compared 20% albumin with 0.9% saline, and it showed no significant difference in the mortality. Then alveol study was published in 2014, which was conducted in severe sepsis and septic shock patient. It compared 20% of albumin and crystalloid, and it showed the improved mean arterial pressure, reduced heart rate, shorter time to the cessation of the vasopressor and inotropic support, but no difference in terms of organ failure, mortality, and post hoc reduced 90-day mortality in septic shock subgroup. Then the RAS study was published in 2019, which compared 40% albumin with ringer lactate, and it showed no significant improvement into the mortality rates. Then in 2021, FRIS study was published in cirrhotic patient with sepsis-induced hypotension, which compared 5% albumin and 0.9% saline. It showed higher rate of hypotension reversal, sustained reduction in the heart rate and hyperleptemia, and a higher proportion of surviving patient at 1 week. Then ALP study was published in 2022 in a cirrhotic patient with sepsis-induced hypotension, which compared 20% albumin with plasma light, and it showed albumin was more effective, faster decline in lactate, reduced need of dialysis, and longer time to dialysis initiation, but similar 28-day mortality and association with the pulmonary complication. Then these are the guidelines which was published in the context of albumin, and they showed according to that, the recommendation one is in critically ill adult patient, intravenous albumin is not suggested for the first line volume replacement or to increase serum albumin level. Then the next recommendation was in critically ill adult patient with thermal injury or ARDS, intravenous albumin is not suggested for volume replacement or to increase serum albumin level. Next recommendation was the in critically ill adult patient, intravenous albumin in conjugation with the diuretic is not suggested for the removal of the extravascular fluid. So it is our reflex action in the ICU. If we'll see the serum albumin level is less, then we are adding this, then we are administering albumin to increase the serum albumin level, but it is the wrong practice. And the another practice which I have seen commonly in the ICU is to increase the, if the someone's urine output is less, then most of the physicians are prescribing albumin with diuretic, but it is also against the guideline. Now we'll see the what are the recommendation in critically ill pediatric patient with severe patient. In pediatric patient with the infection and the hypoperfusion, intravenous albumin is not recommended to reduce the mortality. In preterm neonate that is less than 36 weeks with low serum albumin level and respiratory distress, intravenous albumin is not suggested to improve respiratory function. In preterm neonate of less than 32 weeks and of weight less than 1.5 gram with or without hypoperfusion, intravenous albumin is not suggested for volume replacement. Then, if patient is undergoing kidney replacement therapy, then in those patients, intravenous albumin is not suggested for the prevention or treatment of intradialytic hypotension or improving ultrafiltration. Then, in adult patients who are undergoing cardiovascular surgery, intravenous albumin is not suggested for priming cardiovascular bypass circuit or volume replacement. If in pediatric patients who are undergoing cardiovascular surgery, intravenous albumin is not suggested for priming cardiovascular bypass circuit or volume replacement. Then recommendation in cirrhotic patient. In patient with cirrhosis and ascites undergoing large volume paracentesis that is more than 5 liter, intravenous albumin is suggested to prevent the paracentesis induced circulatory dysfunction. In patient with the cirrhosis and spontaneous bacterial peritonitis, intravenous albumin is suggested to reduce the mortality. Then, in patients with the cirrhosis and extraperitoneal infection, albumin is not suggested to reduce the mortality or kidney failure. In hospitalized patient with decompensated cirrhosis with hypoalbuminemia, albumin is administration of albumin to increase the albumin level to more than 30 gram per liter is not suggested to reduce infection, kidney dysfunction, or death. Then in outpatient with cirrhosis and uncomplicated ascites, despite diuretic therapy, intravenous albumin is not routinely suggested to reduce complication associated with the cirrhosis. So I can say in summary, the albumin is advised only in two conditions. That is, in spontaneous bacterial peritonitis and in cirrhotic patient with ascites, if we are removing for more than 5 liters of the fluid. Otherwise, albumin is not advised in any other condition. Thank you.